The Hello, good morning, dear colleagues. I'm here for the first of this group of 5 online webinars that will be held on this platform for the second time. The first time we talk about endodontics and so on, but this time the platform asked me for a presentation about tooth preparation in restorative and prosthetic dentistry. So I have planned to make a group of 5 lessons, and this is the first, will treat the topic of adhesion and its effects on restorative and prosthetic procedures. We will talk about the adhesive technique with a theoretical point of view. We will discuss build-up technique for direct and then indirect restorations, both in the anterior and in the posterior area. We will deal with the restoration of endodontically treated teeth and the treatment of the deep proximal lesions with the subgingival restoration. And so the topic is the tooth restoration in the adhesive era. What does it mean? It means that once we were walking like in the old masonry with the cement and bricks, now we are in the era where buildings can be printed with new techniques. And also we in dentistry have some new technique that help very much in doing our profession, our work. It's obvious that some things hasn't changed. We have always to deal with the problem that is named dental caries for most of our time. Dental caries that goes down in the deep of our tissues, making a lot of problems that we can solve with our techniques. But we must remember that the end is always the restoration that must give back our teeth to a function, restore function, and restore aesthetics. If we fail to do this, the end will be not so good, like in this case where an endodontic lesion was perfectly healed, but eventually the tooth was extracted. Why was extracted? Because we had very precise and good techniques that were based upon the use of very rigid materials, both as restoration materials and as cements and the materials used for the luting of these devices. The final result wasn't so bad, but we didn't take into account the structure of the teeth, the various layers that were very well known with an aesthetically point of view, but not so very well known from a functional point of view. We and our technician were very able in reproducing the various layers of the teeth with ceramics or even with composite, but we didn't take into account the deep structure of the tooth, where there was once pulp tissue, so a very soft material. We put metal or zirconia, and this probably was not the best idea because we had a very, and we have today, a very big risk that is the fracture of the root, the vertical root fracture that leads to the need for extraction of the tooth. We had also another problem, not only the materials of the restoration, as I previously said, but also the cement that was used for the cementation of these devices. The cementation that was performed using very rigid materials that didn't have any adhesive property. So, what was the fate of this material? Invariably, there is a gap between our restoration and especially indirect restoration and the margin of the preparation. And as we see with these micrographs, we can see that a gap exists. The cement is dissolved during the years, and then biologic products will grow in this gap. Now it can happen everything. In most cases, the dissolution can go ahead, determining the failure of the restoration, or caries can develop on the root. Anyway, this was the what we had about 35 years ago. Now I'm showing you some restoration performed 35 years ago with no adhesion technique for reliable for especially for the deep tissues of the teeth. We had something that worked quite well on enamel, but nothing that could withstand the forces of mastication for the dentin. So these were works made with pinledge. They were very narrow pins that were drilled in the safest area of these teeth. In this case was a genesis of the lateral incisors. These are the bridges that were used, I repeat, 35 years ago. And now you can see on your right, you can see the result after 35 years. They are still working. The teeth have moved a little, but nothing dramatic, and the patient is still satisfied. But we now can do something better because we have adhesion. Another case of a tooth treated more than 30 years ago, and then this patient married a colleague, a dentist, and so she's not my patient anymore. But this bridge, I know it's working after 35, more than 30 years, not yet 35, but more than 30. These were performed without the use of adhesion and were based mostly on mechanical principle. Biological and aesthetic principle were on the same level of the mechanical principle. Now there is something new. because we can leave more space to biological and to aesthetic principle, and we have less need for mechanical issues because we have the possibility to make adhesion to the tooth structure. And also, this adhesion has a long story. This is almost always forgotten. Oscar Hager had a patent about a cavity seal that performed some kind of adhesion. Then we have Bonocore and so on. What is adhesion anyway? Leaving aside the history, is the micromechanical retention resulting from acid etching of dentin and enamel, and the chemical adhesion, a true bonding that works through molecular interactions between adhesives and tooth surfaces. And we have one more principle that is not so often cited with adhesion, because I have shown you that we use the rigid cements, but now with the advent of adhesion, we use cements that are not so brittle as the cements that we used previously, are ductile, so they can perform much better than before. And so let's deal with the adhesion to enamel and dentin. Historically, adhesive systems are classified in generation that mean the era of the chronological appearance on the market of these products. This I don't like this kind of classification because we have some problems. It lacks objectivity, has no scientific base, and can create confusion and misinterpretation because it looks logical that the new generation are better than before, but this is not always true. So we prefer to use another kind of classification that takes into account the type of adhesive, that the technique that can be etch and rinse, can be self-etch, and can be universal, further divided in the number of steps that every technique uses. Another variable is the use of total etch or only enamel etch. And so we have this classification that is much better than before, much better than the one that deals with generations. So currently, etch and rinse, self-etch, and universal adhesive systems are the main strategies that we have to promote the adhesion of composite resins to the dental substrates. The etching is performed using phosphoric acid that achieves, that optimizes the enamel surface conditioning. And the best approach to the dentin surface is still a little controversial because of the heterogeneity of the structure and the hydrophilicity of the dentin. The quality